Good evening, ladies and gentlemen. Welcome to another exciting episode of Blood, the Life Savior. And we are about to reach our 1 year landmark. This time it is episode 11th. And we have presenter from none other than Apollo Hospital, Chennai. And they have a very intriguing and exciting topic beyond engraftment, navigating infection, immune dysregulation, and multi-system complications post-haplo in toxic deficiency. And Revti ma'am, we all look forward for a very interesting and exciting discussion as well. All this has been possible because of untiring guidance, support, and mentorship from our course directors. Warm welcome to them, Dr. Viju George and Dr. Joseph Johnson. Thank you, sir, for all this help for last 1 year. And also a warm welcome to all the faculties from Apollo Hospital, Chennai, Dr. Revati Raj, Dr. Vidya Krishna, Dr. Tulasi Raman, and Dr. Vijayashree Muthukumar. Thank you for spending time with us. We all know that starts on time and this finishes in time. On an average, we commit to you that we'll relieve you by 90 minutes. It's my honor and privilege to introduce our program director, who needs no introduction to the field of hematology, Professor Dr. Biju George. We know Sir is attached to the most prestigious institute from Department of Clinical Hematology at CMC Hospital, Vellore. Sir is also a clinical scientist with more than 2 decades of clinical experience and scientific experience in managing hematology's disorders. Dr. Viju George is also Vice Chair, Asia, Africa, Australia, and Advisory Committee for CIB MTR. Close to 300 plus publications, contributions in more than 6 book chapters. But what we also know that he also developed the fludarabine and cyclophosphamide conditioning protocol for aplastic anemia, which is now a national standard. More than 200 plus haploidentical transplants initiation, and Sir's area of interest is into stem cell transplant and infection management and bone marrow failure disorder. Thank you, sir, for your guidance. Our second program director, Dr. Joseph John, one completes South, second completes North, Professor and Head Department of Clinical Hematology at prestigious CMC Hospital, Ludhiana. More than 30 international and 38 national publications, contribution to 7 book chapters in prestigious national and international publications, PI of more than 20 plus clinical trials. But what we also know that he went on to do establish clinical hematology and stem cell transplant in northern part of India at CMC Vellore. And he founded Comprehensive Hemophilia Care Center and later a center of excellence in much needed northern part of India. Thank you both our program directors and may I request both of them to take it forward from here, sir.
Thank you so much, and welcome all the participants who are taking part in this webinar. So we'll just quickly move on to the presentation. So this is from Dr. Revati and her group. I mean, I'm sure anybody who's attached to transplant and especially pediatric transplants knows Dr. Revati, well-known figure in the field of transplantation in India. And she and her team are going to be talking about Dockade deficiency and the problems that can happen during a haploidentical transplant in Dockade deficiency. Over to you, Revati. Go ahead.
Good evening, and thank you to the entire team for the opportunity. We have two really good leaders here, both Biju and Joseph are good friends. And as I said, just looking at the case series presented, the discussions, and our team, everyone wanted to be part of this because every week there's such a good learning experience. So I hope you do more of these sessions. And thanks for the opportunity today. Our team today, we're very fortunate to have Dr. Tulasi Raman with us, and he is hematopathologist at our lab, and he has a special interest in immune deficiency. So, flow cytometry is his area of expertise, but he also helps us interpret the raw data that comes from the NGS sequencing that we get for our patients, and every aspect and how to follow up immune reconstitution post transplant. So, if we are where we are with the diagnosis of immune deficiencies at our center, it's thanks to Tulasi's interest. And he's also someone who's enthusiastic about teaching. So happy to have him here. The other panelist here is Dr. Vidya Krishna. She's one of the very few people who have both pediatrics and infectious disease fellowship, and that too has specialized in transplant infectious diseases. So I saw a dramatic difference in the quality of interactions after her stint at Great Ormond Street. And we're really privileged to have her in our team because we are doing some of the most complex cases, and having young people like her in our team and treating these challenging cases and having discussions about them is a learning experience. And I'm sure what she has to share today about this particular case. And we know for sure that he is where he is today, this particular child, because of all her inputs. And the last of our team today is Dr. Vijay Sri Muthukumar. So she is fellow in the pediatric blood and marrow transplant unit. So we do a 1 year fellowship program for pediatric BMT. So she's finished HEMONC and she's come to do transplant fellowship, and forever keeps challenging me to learn, to teach, and is a great asset to our patients. So we'll start with the presentation from Viji, and how we are going to do this is as and when there are areas of diagnosis, Dr. Tulasi Raman will talk about it, and with the infections related, Vidya will give her inputs, and the transplant related parts, I will give my inputs. Over to you, Viji.
Thank you, ma'am. I'd at the outset like to thank the academic series for giving me this opportunity. So, diving into the topic, today we're going to talk about navigating infections, immune dysregulation, and multisystem complications post haploidentical HSCT in a child with DOCK8 deficiency. So, just a brief introduction. We know that DOCK8 is an autosomal recessive combined immunodeficiency. Earlier, it was classified as a part of the autosomal recessive hyper IgM syndrome, but now we know it's a combined immunodeficiency as per classification, and it occurs due to a loss of function mutation on chromosome 9, where the DOCK8 gene is located. Its presentations are hallmarked by eczema, recurrent infections, viral susceptibility, and a risk for malignancy. And at the base, it is a T cell dysfunction because of impaired cytokine signaling, because of which they have poor viral clearance. So presenting the case today, we had an 18-year-old male who presented from Telangana. He had issues right off from infancy, where he presented with recurrent lower respiratory tract infections requiring multiple admissions. He also, by the age of 13 years, had severe atopic dermatitis, which was poorly responsive to topical steroids, and it was so severe that it warranted a dose of rituximab. By the next year, at 14 years of age, he had developed refractory autoimmune hemolytic anemia, and that required prolonged immunosuppressive therapy with oral steroids. And when it was not responsive to oral steroids, he went on to receive MMF and azathioprine. It is at this point that he was evaluated probably for some other underlying immunodeficiency, because he already had multiple respiratory tract infections, skin manifestation, as well as a hematological manifestation of autoimmunity. But by then, by 17 years of age, he developed inflammatory bowel disease, diabetes, and at this time he had to undergo emergency hemicolectomy for small bowel obstruction with perforative peritonitis. So you can see by the time he presented to us at 18 years of age, he already had a poor quality of life with multiple morbidities related to his presentation. So this is how he initially presented to his rheumatologist. The baseline CBC, what we have here, showed a hemoglobin of 8.9 gram percent. Total counts were 6,370 with a platelet count of 2.63 lakhs. And at this time, he also had a Derek Coombs test positive at 4%. When the TNB markers were done, it showed a low CD3 count. The STAT3 mutation analysis was negative, and this here shows his immunoglobulin profile. So you can see that he had a low IgM level and a very low IgA level. So with this, the rheumatologist who was treating him did send in a whole exome sequencing, which showed a DOC8 mutation in exon 6, and that was followed up with Sanger sequencing to confirm that it was indeed a pathogenic mutation, which was homozygous. So at this point, I'd request Tulasi sir to please tell us about what these reports mean and how to interpret them given this clinical presentation.
So, hi, good evening, and thank you, the respected professors and seniors, for this opportunity, right? So, of course, this is a very interesting case, and I'll just give you the insights about how the diagnosis is done in these cases. So, could you just go back to the previous slide, please? Yeah, this slide, perfect. So, of course, so any immunodeficiency, when you have a high suspicion based on the Jeffrey Mondale criteria, so we normally do a screening of a PID screening or an PID workup, like a package where you include your lymphocyte subset analysis and the immunoglobulin profile along with it, the NBT and stuff. So this is a case where you find a reduced CD3 count. Now, the reduced CD3 count, when you have a reduced CD3 count, provided there is no steroid or given, and if this absolute CD3 counts are low, definitely you are dealing with something like a combined immunodeficiency, provided we have not given any steroid therapy or something which iatrogenically can bring your CD3 counts down. So reduced CD3 is something like a combined immunodeficiency. I would love to see, and we definitely these are combined deficiency. You need to see your CBC also. Sometimes CBCs are overlooked. See, when you have combined immunodeficiency and when you have eosinophilia in the CBC, see, then your differentials are a bit narrowing down. Before you go for exotic flow cytometry and NGS, when you have reduced CD3 count and you have eosinophilia and hyper IgE, now your diagnosis comes to say 4 or 5. One is your DOC8, the other is, of course, the counterpart, autosomal dominant hypereosinophilic syndrome, then the Wiskott-Aldrich, and of course, Owen syndrome. So your diagnosis almost gets narrowed down. So this child already have some skin lesions. If eosinophilia is there and there is increased IgE levels and there is reduced CD3, so now we do something like an extended lymphocyte subset. So this CD3, again, we see CD4, CD8, and the CD4 again is split into naive, memory, and the effector cells. So this will give more insight. Even if the patient has received steroid and the CD3 count is low, now just looking at CD3, CD4, 8 may not tell you whether it is immunodeficiency or something secondary lymphopenia, which is caused by steroid or some other reasons. Now, if your naive cells percentage is reduced, then it is more likely to be an immunodeficiency, PID, or inborn errors of immunity. If the naive percentage is maintained with reduced CD3 count, that means it is maybe a steroid driven or something else. So then secondary lymphopenia is something which is to be kept. So this case, CD3 is low. Obviously, the naive CD3, CD4 and CD8 should be low, and there is eosinophilia. So this is something which gives a high suspicion that this is a case of combined immunodeficiency with eosinophilia and hyper IgE. So narrowing your diagnosis to 4 PIDs. Now, if you come to the second part of the screening, which is your immunoglobulin profile. So here you can see one very classic is decreased IgM. Now, what is the use of this decreased IgM is when you have a differential of hyper IgE syndrome. So you have the autosomal dominant one and the autosomal recessive one. Docket comes under autosomal recessive. And in contrast to autosomal dominant hyper eosinophilic syndrome, autosomal recessive eosinophilic syndrome will have decreased IgM. So when you check with autosomal dominant hyper eosinophilic syndrome, IgM will be normal. So that is again, so these are some small findings. Sometimes when we pay attention, you can able to narrow your diagnosis, because I'll tell you what, now this is a period where a lot of whole exome sequencing, whole genome sequencing, targeted sequencing are done. But when you are not narrowing your diagnosis and you just send the sample for whole exome sequencing, it throws a lot of variants, which puts you into a lot of confusion, which variant you need to call it pathogenic or which variant you need to neglect, right? Now, this is something which is, so this particular slide tells me that this is a case of combined immunodeficiency, possibly with eosinophilia and reduced IgM. That gives us more insight towards that this could be an autosomal recessive Docket hyper eosinophilic syndrome. Could you just go to the next slide, please? Yeah, so now, of course, this is the whole exome sequencing. You can see that this is an autosomal recessive pattern of inheritance. So both your genes has to be knocked out. So it should be a homozygous zygosity. So when you have a autosomal recessive inheritance, both the genes should be knocked out. And of course, this is satisfying the homozygous zygosity shows that both the genes of Docket has been knocked out. Right, and you can see this is an insertion, which I can show it in Sanger also. So between the nucleotide location between 560, yeah, no problem. So 560 to 561, okay, there is insertion of 5 nucleotides. So that you need to interpret. So I can show you, this is Sanger. You see, this is the control, normal. And this is the patient. You can see there, normally after this particular nucleotide, you should get this, right? This is A and this is C. So this is normal. But here there is an insertion of A, I could not see that, E, C, and G and A. Okay, so there is almost like 5 nucleotides which has been inserted, which is not present in the normal reference genome, which means there is a 5 nucleotide insertion. What happens because of this insertion is, normally when you read the DNA for protein synthesis, the RNA and the DNA will be read in a triplicate. 3 nucleotides will be read together for a codon, that we call it as a codon. Now, because of this insertion, the reading codon will be changed. Say, for example, now, if it is going to finish till here, now it can go end here and it can go to produce an abnormal protein. So when an abnormal protein is produced, there is loss of function. So this dedicator of cytokinesis 8, which is called the DOC8 protein, is abnormal. So it doesn't do its function. So you need this protein for the cell to move around. It's a cytokinesis, so it moves around. And for migration, if this protein is abnormal, there is a problem in the cell migration, especially the T lymphocytes. So both adaptive as well as the innate immunity, and also the STAT3 translocation between the it will be like a shuttle going inside the nucleus and coming to the cytoplasm. Even that will be abnormal due to this DOC8 deficiency. So this is Sanger. Sanger is always gold standard, provided if you have got a mutation in your NGS, and if it's a large deletions, all those things can be missed in your NGS. So Sanger is something really good to confirm your NGS mutation. Something like MLPA is also another technique which you can confirm. So this is homozygous, I repeat. So both the genes are got knocked out, and there is an insertion of 5 nucleotides, which is resulting in the change in the reading frame, leading to an abnormal protein formation, which does not do the function, right? Yes. So next slide, I suppose.
So,
That's fine.
Tulasi, I think
Yes,
for
ma'am.
people who are listening, the immune deficient patients don't just present to us to say, hey, I have had so many infections or I
Yes.
have atypical infections.
Yeah.
Some of them will present with recurrent and difficult to treat autoimmunity. So, right
Yes.
from the beginning, this child actually had all the signs of a primary immune deficiency in the form of refractory skin eczema and immune cytopenias. So they can present to hematologist or they can
Yes.
present to, so some of them present to gastro with inflammatory bowel disease. And
Correct.
in fact, he needed to have an emergency gut surgery for bowel inflammation. So before we go to that extent, if we have a good instinct to do the primary immune deficiency workup early, he need not have spent so many years of his life on steroids and have the morbidity associated with long-term steroids.
True.
So it's mostly a high index of suspicion, and the immune deficiencies that present to us with autoimmunity are going to be far more challenging than those who present to us with just infections.
True, very true, ma'am. That is the reason why the name PID has been changed to inborn errors of immunity in 2019, because you have a big set of, you have 10 categories of inborn errors of immunity, of which three doesn't present with infection at all. They present with autoinflammation, autoimmunity, and so especially your complements and immune dysregulatory disorders. Very true, agreed, ma'am. That is right. So that is why you have a high suspicion. You have a package, screening like package, which includes your basic immunoglobulin profile and your lymphocyte subset analysis. Because if you do these two, obviously you can pick most of the cases. And the lymphocyte subset, when I say, I would recommend not just doing your CD3, 4, 8, 19, and 56, which just says about your NK cells, B cells, T cells. Rather, you can do a good extended lymphocyte subset, because as I just gave you an example, even when you give steroids, the T cell count can go down, and it may mimic like a immunodeficiency when you do just a basic panel of CD3, 19, and 56. But when you do an extended panel where you can split that CD4, CD8 into naive memory, central memory, effector memory, you know whether this is a case of immunodeficiency or is it a secondary lymphopenia, which may be because of steroids or any other causes. So that is something we can do to pick up these cases.
Also, another thing we've learned from you is not to look at percentages, but with
Yes.
absolute values. And for every age group, the absolute values
Perfect.
change. So we have to look at what age group we're dealing with.
Yeah, that is 100% right, ma'am. You added upon. So this values should be definitely inferred with the age specific reference range. If you're not putting a general reference range, then everything looks immunodeficient or everything looks normal. So you have to do it with the age specific reference range. Make your laboratory that they give an age specific reference range with the correct values. Second important point is, I normally insist on doing a phenotype genotype correlation. If somebody has said something abnormal, or clinically you feel abnormal, or flow wise I have said like there is an abnormality, and if the genetic doesn't show that, there is something you need to recheck the phenotype, and you need to recheck the genotype, vice versa. So for example, if I'm not suspected something, but when I sent it for an whole exome sequencing, some variant is thrown out. Now you can't just neglect it saying like, no, this is something not specific, but still go back and see. We can have some that same phenotype, maybe not expressed so well, but still it could be there. Retrospectively, you can able to pick it up. This is called a phenotype genotype correlation. I would say for any inborn errors of immunity or any inborn errors, you should do the phenotype genotype correlation. Just don't take the phenotype results, or just don't take the genotype results independently. You need to correlate both of them, and before you keep the diagnosis, it should match. Yeah.
Thank you so much, sir.
Thank you.
So moving on, when the child presented to us at 18 years of age, there were no unrelated donors, and the haploidentical brother was selected. We also did the brother's Sanger sequencing, and he was heterozygous for the DOC8 mutation. So because of the refractory autoimmune hemolytic anemia, we had planned to give 2 cycles of pre-transplant immunosuppression with bortezomib, but that was also a challenge because he had persistent leukopenia, and it was complicated by an episode of salmonella gastroenteritis. During this episode, when we screened him prior to transplant, we also found that he had CMV retinitis with viremia, so he needed both intravitreal as well as intravenous ganciclovir, and it was later changed to oral ganciclovir when the viremia settled, and this further complicated the leukopenia. He also had an acute febrile illness during the PTIS period, and eventually he cleared the adenovirus, CMV, and EBV from the blood before transplant, and we also did a whole body PET to look for any active infections, and none were there. We proceeded. He did not have any donor specific antibody. We did a single antigen bead assay. Both class 1 and class 2 were negative. We did offer sperm banking prior to transplant, but he declined. So when we took the child up for transplant, we offered TCR alpha, beta, and CD19 depleted peripheral blood stem cells from the haploidentical brother. Both the donor and the recipient were CMV negative. And the peripheral blood stem cells, when we gave, there was minor ABO incompatibility between the brothers. We gave them 16 times the CD34 cells, and the conditioning that he received was RATG, fludarabine, tiotepa, and triosulfan, along with 2-gray TBI. Post this, the child engrafted on day plus 11, and initial chimerism itself was complete at 100%. But as soon as the stem cells came up, he was also having fever, mucositis, gut toxicity. But immediately post engraftment, he had CMV viremia again and was started off on ganciclovir. He had a lot of nausea and had poor oral intake, and we initially itself did an upper GI endoscopy and biopsy. There was no CMV viral inclusions or GVHT, and that nausea eventually settled a week later, and he was able to tolerate soft solids orally. But however, on day plus 16, he again presented with cough, and the CT chest showed ground glass opacities, and he started empirical antibiotics, and even these symptoms settled down. And again, on day plus 35, he had skin GVHT in the form of erythematous macules all over the trunk, and we increased the dose of steroids, and these rashes reduced as well. But the major complications started on around day plus 60, when he initially had a pea-sized painless nodule, which was noticed over the right foot. You can see that in the image. But however, in the next 2 to 3 weeks, he started having similar lesions appear over the scalp and the limbs. So this was more diffuse when it developed over the hands and the trunk, and it was erythematous, and it was like a raised macule. And we initially thought this was skin GVHT and further increased the dose with prednisolone. We also thought that this could be some form of cellulitis and added a gram-positive cover with teicoplanin. At this time, we also noticed a fall in the WBC count, and the platelet counts were also slowly falling. He was also on ganciclovir for the CMV viremia at this point. But very quickly, these lesions worsened. You can see over the face how over a span of a couple of weeks, it was so disseminated. They started having these nodular appearances, and it was all over. And you can see this last photo is actually after 2 weeks of treatment, but it was very rapidly progressive. And when we did a biopsy of this lesion, the smear itself showed a lot of acid-fast bacillus, as you can see in the picture. However, the gene expert was negative. The histopathology showed granulomas with inflammation and many acid-fast bacilli. However, the blood for mycobacterial cultures did not yield any growth. So when we did a Bactifast, that's when I think it's not very clear, but if you can see at the bottom of the slide, it says that the sequence alignment is in keeping in line with the Mycobacterium avium complex. So at day plus 65, he was treated for disseminated non-tubercular mycobacterial infection. And initially, he was started on imipenem, tigecycline, amikacin, levofloxacin, and clarithromycin. We, of course, cut down on the steroids and stopped once we found the acid-fast bacilli. But by day plus 80, once we got this report, we altered his mycobacterial cover for slow-growing mycobacterium and included HRZE with linezolid, levofloxacin, clarithromycin, and amikacin. So only after this, on day plus 80, when we changed this, did the fever settle. So I'd request Dr. Vidya ma'am to please tell us about this finding and the ATT cover that we gave him.
Good evening, everybody, and thanks for this opportunity. This was one of the most challenging patients we've had. In starting, he already was comorbid and he had gone through quite a bit of infections, and basically it was difficult to manage an adolescent, the family of an adolescent, and the infections on top of it. So if we have to move to this particular thing, at this point in time when he presented with a nodule, initially he only had a nodule, he didn't have much of systemic symptoms. And then when I think that's when they were thinking more of GVHT and then other things. But once the systemic fevers and other symptoms started, it looked like it was going to be a disseminated process. He did have imaging of his chest, abdomen. Nothing showed up in the chest or in the abdomen. It was all a diffuse cutaneous manifestation. And we were thinking in lines of anything and everything. We thought it could be bacteria like staph, strep, mealy, Burkholderia. We thought it could be a disseminated fungus like trypto, sporothrix, or histo. And then we also considered mycobacterial disease. I think with docket itself, the risk of mycobacterial disease probably is lesser than, say, bacterial or fungal. But then still, there is a possibility that they could have. But his timeline post HSCT, it was somewhere after 60 days that he presented to us. At this point in time, when we think of mycobacterial disease, it could be either a rapid grower or slow grower. Rapid growers generally are associated with line infections, catheter-related bloodstream infections. Like when I say rapid growing non-tuberculous mycobacteria, there are some species like Fortutum, Kilone, which typically grow from central lines. So we have had some patients with that infection also. But when they have cutaneous manifestations, again, it's quite a wide net. Most of these bacteria, they enter the body through inhalation. For example, Mycobacterium avium is typically an inhalational or ingestion. That is how it gets in. But then in him, it looked like it was primarily a cutaneous process. Probably because he has been having long-standing eczema. And when we probed the history also, he had been, for a brief period of time when he was well pre-transplant, he started visiting a number of swimming pools and he had taken up to swimming. So the mom recalled saying that some of these were not pretty chlorinated or swimming pools. So probably he must have been colonized at some point in time pre-transplant. If you go on to see, even this biopsy, only the smear was positive. There was no culture positivity. He had not been exposed to anti-mycobacterial agents before the biopsy. It was more of antibiotics, which should not have affected the cultures. So one point in time, we were actually clinically thinking, could it have been just an immune, it's like an unmasking iris, like what we would do in HIV when you start treatment and then whatever infection is latent just starts coming up. So it probably it was like an unmasking iris kind of a manifestation. And so again, the role of NGS is something that is probably becoming more and more important in this time and age. Definitely when, for the juniors, when you see a skin lesion or any tissue biopsy in a post-HSCT patient, always it's a very gold standard, it's a, what do you say, it's a very valuable sample. It's like a gold or platinum or whatever you want to call it. So it's important to get all your differential diagnosis in place before you process the sample, because you're going to go in once and take the sample and come out. So if you want to plan, just get all your bacterial cultures. In our setting, we have a practice of sending all cultures together. So we call it as a bacteriology pack. It ideally a microbiology pack, but then it's labeled as bacteriology pack in our place. So it includes gram stain and bacterial cultures, AFB stain and mycobacterial cultures, and fungal stain and fungal cultures, so that nobody misses out on any of these things. So when you get a sample, you send it. And usually we always send the histopathology 1, 2, 3. It's histopathology, expert MTB, and bacteriology pack. So once you do this, almost all the organisms that we are considering, most of them would get picked up on the tissue. So in a place like this, where even the routine microbiology has failed to pick up something, and where it was very important for us to know what this mycobacteria was. It could have been leprosy, it could have been TB, it could have been anything that, and it was very difficult for us to make an empiric regimen. So in such a situation, we went ahead and did the it's called the NGS, stands for next generation sequencing. It's like your 16S PCR, like where you pick up the bacterial genome. It's a eubacterial genome, which all bacteria have. The good thing about this test is obviously it is going to pick up fastidious pathogens, like how it has helped in this case. But obviously the caution, which is more, I want to sound the caution more than the advantage. The caution is it will pick up any bacteria. It could be from the skin, it could be from the environment. So sampling and transport and processing is all important. And again, how they interpret the report. Like suppose they see, they pick up, say, 10 bacterial DNAs on that report. Then the microbiologist typically discusses with us, and then there is something called as relative abundance, where they calculate which bacteria is more in number and which is less. And then they discuss with us before they finalize the report. So in this case, from the beginning, we were telling the microbiologists that our strong suspicion is it is going to be some non-tuberculous mycobacteria, either rapid grower or slow grower. And then with that input, they probably looked keenly and then they picked up that it was probably going to be Mycobacterium avium. And that really that day was a game changer for us. It helped us to narrow down. And then he was not at all a child who was compliant with any medication. It was, he had gone through so much. And on top of it, we were giving him a lot of intravenous and a lot of oral medications because we just wanted the fever and the nodules to go away magically. It was, he was not too sick, but then obviously it's difficult to see somebody suffer like that in front of your eyes every day. And then this test, when the day, I still remember the date when it came. And we had a resident from US who was rounding with us. In fact, I wrote back to her saying that finally we have a clue to why this boy is having this infection. And it probably, and it really helped us to move forward on this case. So there are quite a lot of challenges. So I'm going to stop talking here and then we will come back again.
Thank you, ma'am. So you can see that the infectious timeline not only included the atypical tuberculosis, which took almost 300 days for him to clear. He had CMV that reactivated right after he engrafted all the way up to day 150. He also had significant period of adenovirus for almost 100 days. And he had multiple respiratory viral infections with respiratory syncytial virus and COVID. So you can see how the CMV titers and adenovirus titers took a very long time to clear, and he also had a lot of complications related to CMV, which I'll enumerate now. So he reactivated by day plus 11 itself, but by day plus 90, he had developed CMV retinitis. He also had a few behavior and sleep alterations, because of which we did a CSF analysis and an MRI of the brain. The imaging was normal. However, the CSF analysis, although the cells were nil, it was slightly elevated protein and a low sugar, and the meningoencephalitis panel showed that he had CMV in the cerebrospinal fluid as well. And for this, he received a 6-week course of both intravenous and intravitreal ganciclovir again post-transplant. In terms of adenovirus, he had received 3 doses of cidofovir. And post that, he actually had a diminished vision and headache, and he was diagnosed with cidofovir-induced ocular hypotonia. And we also stopped the ethambutol, which was given as a part of his, tuberculosis cover. And finally, what helped with the adenovirus reactivation was when he was given the virus-specific T lymphocyte infusion from his mother. Actually, only then did he clear his adenovirus. He also had other bacterial infections. He had urinary tract infection with Klebsiella and Pseudomonas. He had sinusitis, which was also growing the Pseudomonas, and he underwent a functional endoscopic sinus surgery for the purpose of sinusitis. So besides infection, he also had significant nutritional and GI complications. Like Vidya ma'am was saying, he was not very compliant with medications. He was not eating well, and because of all the ADT, he was having a lot of vomiting. His BMI had dropped to 12.9, and he also had a lot of issues with NG tube feeding, and multiple times he was not compliant with that. So you can see how his weight dropped between day 100 to day 150. This was around the time when he was actively on a lot of tuberculosis medicines, and he was on CMV and adenoviral medications. So we also did an endoscopy again, and we reinserted the NG tube. There was some amount of duodenal atrophy and inflammation at this point, and we gave him a lot of parenteral nutrition support as well as enteral feeding through the NG tube. And you can see that once his TB medication started working and his viruses started clearing, he had a clear increase in his weight and BMI. In terms of his autoimmunity, 9 months post-transplant, he had refractory autoimmune hemolytic anemia. There was already a minor blood group incompatibility. He required multiple transfusion and again went back on steroids. And because of steroids and probably the cidofovir, he developed bilateral cataract, and one after the other, both the eyes were operated for the cataract, and both of the eyes have 6/6 vision now post the surgery. And of course, with all these in the background, he did have a lot of psychological and social issues. He had clinical depression and somatic symptoms, because of which we had referred him to a psychiatrist, and he was started on appropriate medications. The family too multiple times had a lot of burnout, and there was adherence issues both in terms of nutrition and the prolonged course of tubercular medicines. So in terms of graft dysfunction and stem cell boost, in 2025, he had poor graft function in terms of cytopenias despite 100% chimerism. So he was given a stem cell boost from the brother. He was given 1.3 times into 10 to the power of 6 times per kg. And promptly after that, he developed cytokine release syndrome. Soon after the stem cell boost, he developed respiratory distress, hypotension, and he was observed in the ICU and started on HFNC support and inotropic support. But he had clinical recovery from that in terms of hematological recovery. All the cytopenias resolved, his nutrition improved, and his weight also started improving. And it was only by day plus 271 post-transplant, post the stem cell boost and the viral specific T lymphocytes, did he clear the CMV and the adenovirus. And as of now, he's still on follow-up with us. He's still on the medications for atypical mycobacterium and on multidisciplinary follow-up. So you can see that it took a very long time for his CD4 count to recover and the NK cells to recover, and B cells probably, the longest to recover. With respect to delayed, sorry, my screen's not sharing it. So with respect to delayed immune reconstitution, so this is a feature that's commonly seen with cord transplant and TCR alpha beta depleted transplant. The NK cells and T cells usually start recovering between day 30 and day 100, and initial T cell recoveries because of the peripheral memory T cells. Only then the time expansion happens and the CD8 appear before the CD4. And in PCR alpha beta depletion, there's reduced GVHT risk. But at this cost of reducing GVHT, we're delaying the immune reconstitution when you compare it to a T cell replete graft. And because of this slow T immune reconstitution, we have a prolonged susceptibility to infections, especially viruses, fungus. And this again is what Vidya ma'am was talking about, the NTM. We have the rapid growers, which could affect immunocompetent or immunosuppressed host. We have the intermediate growing, which is what is commonly picked up from the swimming pool. But what this child has was a slow growing mycobacterium complex, that is the Mycobacterium avium complex, which is predominantly a feature of immunocompromised host. And Mycobacterium ulcerans is another one. Yeah, this is just to say that they can also have other systemic involvement like pulmonary cutaneous disseminated, or like Vidya ma'am was saying, it could be even catheter related infections. And chronic GVHT, low CD4 count are risk factors for developing non-tubercular infections. And also the fact that this child had CMV viremia, that also increased his risk of acquiring atypical mycobacterial infections. And the fact that he had received a myeloablative conditioning along with a T cell depleted graft. These are the risk factors in this child's case, which made him predisposed to get an atypical tubercular infection. So I think this, Vidya ma'am, could you just tell us about the mycobacterial cover?
So definitely, it's important to know what NTM species you're dealing with, because the treatment entirely depends upon the species. And actually, it is very important to even get the culture and the sensitivity data, the drug susceptibility data, because most of these non-tuberculous mycobacteria, unlike your TB, they are likely to be resistant to antibiotics. So if nothing like a good culture and sensitivity report to guide your therapy. But at least knowing the species is important. Why? Because when you look at the rapid growers like the Fortutium kilone, they are typically responsive to antibiotics like your amikacin, tigecycline, imipenem, levofloxacin. So these are drugs which we use. Most of the times when we think it is a catheter-related infection due to an NTM, then this is what would be our empiric cover. And then based on the culture and sensitivity, we would tweak it. And most of them would require long-term therapy. If it's a catheter, definitely the catheter has to come out. There is no way that you can salvage a catheter in place with a rapid grower. And then typically we treat them longer. Like if for a disseminated infection, it's anywhere from 6 to 9 months. So if it's a slow grower like your MAC, then as most of the times your first line antitubercular does, except your pyrazinamide, would sort of work. So pyrazinamide is something which is useless here. So in addition to that, quinolones, macrolides are other drugs, amikacin are other sort of drugs which can work depending on the sensitivity. So important again, that's you get, and here in our center, we do something also known as the blood for mycobacterial cultures. So this is done in your regular BACTEC methodology. So if you have a disseminated infection, especially with a cutaneous or a pulmonary manifestation in a immunocompromised host, especially a T cell suppressed host, where TB or NTM is a possibility, even fungi, for that matter, some of them grow in the blood. So in this child also, we tried culturing blood for mycobacterial cultures to see if we could pick up mycobacteria or fungi in the blood. Unfortunately, we couldn't pick it up. So, but that is again a good test which you can use to pick up your diagnosis.
Thank you, ma'am. So, in this child, again, to reiterate, the ocular complication of anterior uveitis and ocular hypertonia are something that we should keep in mind when we give intravitreal cidofovir. And it's very rare, but it's something that we have to keep in mind. So, I'd again request Tulasi sir to tell us about how we, look at delayed immune reconstitution, how we use flow cytometry in, looking at immune reconstitution post-transplant.
So yeah, this is one question which is immune reconstitution. Are we on the right track? No, when sometimes madam calls and ask, this is the post-transplant, is everything okay? What I see is numbers. No, I say like, ma'am, I don't know. I just give you the report. Because when you want to interpret this immune reconstitution, it's not like one time point, you know whether it's reconstituting or not. Because what I mean to say, you need 2 time points where you can see there is a increasing trend. So as you showed, the first thing is the first early signs is where your neutrophils need to come out on day 10. That is all fair enough. After that, the first cell what we expect is NK cells. So when the NK cells are within the range, say when you do it on day 30 post transplant, then we are on the right track. Then the NK cells are engrafted, which is quite good. Then followed by it, you have your CD8. So this is something which I would say, always check for your CD4 CD8 ratio. Post transplant, you will have increased CD8 to CD4. So that should be the pattern. So normally in a peripheral blood of a normal individual, you find more CD4 than CD8, but post-transplant, you have more CD8 compared to CD4. This pattern should be there because the next cell after NK to get engrafted is your CD8. Then you have your B cells and CD4 coming up slowly. Now, what is the difficulty? So why couldn't I can confidently say, yes, things are on right? Because we don't have normal reference ranges established for lymphocyte subset post-transplant. Okay, the reason is there is a lot of heterogeneity because the graft what you are giving is quite heterogeneous. Because for leukemias we give a normal graft, where in PID we do a depletion graft with alpha beta and all these things depleted. So you don't have your normal ranges ready-made available to compare whether the things are all correctly matching with that particular time point post-transplant. So the best way to assess is like you have 2 time points of data, check the trend. If you have the counts increasing, so the NK cell should be the first one, followed by CD8, and then you have your B cells and CD8 happening. If you have the CD4 and B cells slowly increasing, that is something which tells you that we are on the right track. The engraftment is happening quite good. The second important point is checking for the B cells at the later time point where the class switching is happening. That is another thing which you need to do. So if when you're giving a depleted graft, so when you, as you know, the graft is given, you have stem cells along with it. If it's a repleted graft, you have the T lymphocytes also. The T cells, what you give is going to fight against immunity, and then the stem cells will go to the thymus, and then they come out as your a longer immune population, like your from the thymic output, which is as your naive cells, or what they call it as recent thymic emigrants. So even in this scenario, which I told you before, this naive and memory makes a sense. I'll tell you an example. Say, for example, when you give an alpha beta depleted product or a graft to the PID patient, and then you check the lymphocyte subset. For if he has memory and there is no naive in the early point, it's fine, because what you are seeing is all the donor lymphocytes, and still the stem cells what you have infused are not gone into the thymus and they have not come out as naive. But in the later time point, say after say 6 months or 1 year, if you still find there is reduced naive cells and predominantly memory, that is not a great sign, because by now the stem cells what you have infused should have gone into the thymus and the naive cells should have come out. Still you can't expect only more of memory and less of naive. So these patterns are very important. So just make it very simple. uh, the cell and the time point which comes, for example, your neutrophil, then your NK cell at 1 month, then comes your CD8, CD4 and CDB, I mean, and B cells. So this ratio is very important. 8 comes before 4. And then two serial time points. Don't check only with one time point because it may mislead you. You should see a trend with the two time points whether the counts are increasing, and always look at the name and memory. That also gives you an additional information whether things are on the right track. So yeah.
Thank you, sir. So, in conclusion, this child had severe infections and immunological complication post HSCT, especially in immune dysregulated adolescents when they present much later, like Mam was mentioning, with inborn errors of immunity. They require individualized and multidisciplinary care because they're more complex when they present with immunological complication. HSCT achieves disease correction but requires long-term supportive care with prolonged antiviral therapy, nutritional rehabilitation, immune reboost, and psychological support. This is our team. Thank you so much for the opportunity. I'll stop sharing the screen now and request Revati ma'am to please take over.
I don't think I have anything more to add, but I thought uh, Tulasi, Vidya, and Viji all did an amazing job. Thank you so much. What I would say is, Tulasi said he's only looking at numbers in the lab. We can just see a child in the clinic and say whether they have a new healthy immune system or not, because weight gain, that's the main thing. So you look at platelet count post transplant and look at whether they're gaining weight or not. And these two can really tell us whether things are going fine or not. And I just want to add what we're doing differently these days compared to before. And I will just give what we're doing to reduce morbidity and mortality, because this child's experience, we needed cytotoxic T lymphocytes and stem cell boost to get rid of the viruses. As Tulasi said, it takes a long time for the immune system to get reconstituted. So we looked at our immune deficiency patients and we looked at whether we should use TCR alpha beta or PTCY, because PTCY is more accessible, and clearly the viral reactivation rates we saw in both, but the uh, TCR alpha beta depleted, we could actually salvage them. Particularly, we had problems with the LAD and DOCATE, because LAD, to get them to transplant, we used a lot of Buffy-coat and granulocytes, which were laden with CMV. So these groups are very vulnerable, and we had a lot of deaths initially related to viruses. And about one third of the children, mainly it was because of viral infections, more in the PTCY group compared to TCR alpha beta. So adenovirus and CMV were a big problem in the TCR alpha beta group. So what we are doing now is adding memory cells. So when we are collecting the graft itself, we are adding memory cells and giving them letermovir prophylaxis all the way from the starting of conditioning. So these two interventions and adding memory cells to during the transplant on day +7. If you give it at day +1, a lot of the rabbit ATG takes out these memory cells, and this helps viral control. So memory cell add back we have done in about 9 patients. And when we've done the memory cell add back, especially in our immune deficient children, compared to the historical cohort who all had absolute lymphocyte count of less than 500 on day 30, these children on day 30 have had 626 on average. Viral reactivations did occur, but they were more easy to manage. With just ganciclovir, they could settle. We didn't have to use cidofovir and virus-specific CTLs in these children. So, so far, all of the kids we've done with the memory cell add back are alive. So, this is, I feel, the way forward, because in the graft itself, if you add the memory cells, it's not increasing graft versus host disease, but it is improving survival. So engraftment is good, low rates of GVHD, and although viruses are getting reactivated, you can treat them and there's good functional recovery. So it's safe and it doesn't cause GVHD. It does have extra financial implications doing all these graft manipulation, but hopefully these are kids we can treat with gene therapy and they're not going to struggle so much like this boy did. But I think when to do stem cell top up, when to add virus specific T lymphocytes, all of these are important in dealing with these complex cases. There are a few questions in the question box. Vidya, if you can take this.
Yeah.
How do you manage BCG flares in skid babies post transplant?
Yeah. See,
Do you recommend
luckily,
steroids for iris? Yeah.
luckily, we don't see that quite often. They're usually continued on the prophylactic medications and they seem to do well. But then, if I think it's a center specific preference, I would be more comfortable to use steroids. But I do know that many people worry about steroids causing lymphopenia. And I mean, in the center where I train in the UK, generally giving steroids was considered to be a little, they would be very wary of using steroids because they would think that the lymphocyte count wouldn't come up. So there, obviously, the practice was to check LSS more common. So when you follow the lymphocyte subset, then it's always worrying. Here we, luckily because of cost, probably do not do the lymphocyte subset so commonly, and then we go clinically. So probably giving a short course of steroids would be helpful. Thalidomide, for that matter, is very well studied in children, but it is still a little toxic drug. Like GI toxicity, hematological toxicity are known to happen with thalidomide. So personally, I don't have much experience using thalidomide, and I'm more comfortable using
Even we've
steroids, though
never used
literature would
thalidomide
support
in infants.
thalidomide.
Yeah. Yeah, even we've never used thalidomide in infants. So, yeah, steroids, yes. Vasundhara has asked 7-year-old male with pre-B ALL manifested with severe immunological phenotype, recurrent infections, multiple dress episodes, and recurrent pancreatitis. So, they did immune deficiency. Only VUS was detected. So, what are the potential mechanisms? I think this goes to Tulasi for a cryptic second hit. And what is the next step to confirm the diagnosis? And would you offer curative HSCT?
Uh, okay, so now the question, like, see, there is a single heterozygous. So now again, what is the gene? This question, I cannot give you a complete answer because what is the gene that is mutated? What is the pattern of inheritance for that particular gene? Now, if it is autosomal recessive, then this single heterozygous VUS, I don't consider currently. And if it is dominant, now one single gene is enough to cause the disease. Now I take it seriously. Definitely I would work up, do a segregation analysis, which means like I will check the parents, or to check for is the same gene there in the parent, any one of the parent. And then I will also definitely do the correlation, phenotypic correlation. And then I would push it from VUS to likely pathogenic. Right now, what about the potential of a second cryptic second hit? Unless you again by NGS demonstrate it, you cannot take it, because now it's already a case of pre-BLL. Now this one definitely, unless otherwise you prove it by NGS that that gene is mutated. If it's recessive, both genes has to be either homozygous or compound heterozygous. It has to be mutated to take it up as a disease. Otherwise, this is still stays as a VUS.
Okay, thanks. There are questions about stem cell boost. So we do CD34 selection, not the TCR alpha beta depletion, if we feel that there is poor graft function. The memory cell add back does not increase viral infection risk. It only helps fight viruses, because these are memory cells which help you fight viruses. So at the time of collecting the stem cells itself, these are cryopreserved in little aliquots, and we give in escalating doses. So it's quite safe, and we've not had any problems with regards to GVHD, but the viruses come down with the memory cell. And lastly, adoptive T cell therapy. So these are not HLA restricted. So you're collecting the T cells that are only against adenovirus. So here we chose the mother, but people are looking at off the shelf adoptive T cells, which hopefully will come in the future. But it made a dramatic difference to two of our immune deficient patients who could not fight viruses. Remember, this child had had so many cidofovir doses that he had eye toxicity, nephrotoxicity, so many. So, thank you all for the opportunity. I learned a lot by looking at this case and thinking about what we can do. And thank you again to Joseph and Biju and the team for the opportunity.
There are a few more questions,
Mm.
I think, in the chat.
I
Adoptive
think we
resource.
offered we've answered all of them.
Answered all of that. Okay, so I
Yeah.
have a few questions to you. This the add back of the adopted T cell. So at the beginning itself, you're collecting and keeping those while you're doing a T cell alpha beta.
Yeah, so memory cell add back, the memory cells are collected at the time of collecting the stem cells and cryopreserved. Definitely, we are doing one on day +7. And then after that, look at day 30 T and B cell markers. Based on that and the viral infections, whether we do one or two more add backs depends on how their immune system reconstitutes. So we have usually at least three aliquots preserved.
So another question is, since you are doing alpha beta, what is the necessity of bringing ATG towards the -3 to -1 rather than taking it farther away from the infusion of the graft, transfusion of the
So,
graft?
yeah, so good question, because we have thymoglobulin and grapholon. The theory behind using grapholon in immune deficient patients is that it's shorter acting, and so it's not there to have an effect on the graft that much. So that's why you can bring it closer to the graft, and it's not there in the blood for such a long time as thymoglobulin, which is there for 21 days. So when we are doing T replete, we do early thymoglobulin and use PTCY. When we're doing T deplete, we use grapholon, and this is a much smaller dose. If you see in the immune deficient patients, they're getting a very tiny dose in our protocol, and immune reconstitution is much better with this. And for all of them, we add rituximab on day -1. Once we've done that, we are not seeing autoimmune hemolytic anemia later.
So you compared the alpha beta and the PTCY here, and what would you prefer at this point in time? I mean,
Immune
in
deficient
terms.
patients, without a doubt, TCR alpha beta in all immune deficiencies, because the outcomes are much better.
So anyway, from my side, it is truly impressive work from all the lab, the ID, and the clinical. I'm sure you have had a lot of sleepless nights discussing over this patient, and it is truly worthwhile. Over to Dr. Biju for his remarks and questions.
No, I think it was a fantastic presentation, Revati. It's really great to see that. Just one question: this adoptive T, not getting the CMV CTL. So, where do you get it from? It's made in-house or
No, no. We have outsourced it to Cytocare.
okay. Yeah.
So
So,
would you then send your donor cells well ahead in time to keep it ready?
So they first do the testing to see if they have enough material to collect, because if they don't have enough T lymphocytes against adenovirus or CMV. In fact, first we tested the dad and then the mom, because the brother had gone abroad, who was the donor, so he was not available. So the dad's was a total failure, and he didn't have enough. So the mom we used, and they go through a lymphocyte donation, and then from that it's collected. It takes about a week, 10 to 14 days for them to prepare.
And if I may ask, the total cost involved in the entire process, is it 1.5, 2? How much would it come?
So, the TCR alpha beta memory cell add back CD19 depletion is a 15 lakhs for just the graft manipulation. Then, of course, you need the transplant with all the triosulfan and thiotepa, which are expensive drugs, and monitoring for CMV, EBV, all long term. So what other costs? So if you have to do a stem cell boost, that is another 7 lakhs.
Hmm.
So because we have to go back and do CD34 selection again. Yeah, so
So
it does.
1.5 CR it will come, right? I mean, this whole process of taking it through at different stages.
I don't know how to quantify this, but yeah, it's a lot of money. Yeah, I know
Yeah.
you are better at calculating how much,
No, no,
but
I'm trying to understand how you counsel a patient. Okay.
no, actually, you are right, because immune deficiency, especially those with autoimmunity, if we take up, it is better to say that the budget is going to be very high. Yeah.
This letermovir coming in, would it, I mean, it's a kind of a savior drug which you can kind of bank on.
Absolutely. Absolutely. For immune deficiency, because as soon as the WBC goes up, you can see the CMV jumping up logarithmically in these children. So now it's made a huge difference.
So this poor graft function problem, how often are you seeing? I mean, is it one-off in immunodeficiency, or are you seeing it in haplos, in Luke's haplos as well?
So we do a lot of hemoglobinopathy haplos. So in that, the patients who've had a lot of panel reactive antibodies, they don't have to be donor specific, but the PRA positive ones tend to have a higher chance of poor graft function. But they usually respond to a combination of romiplastid. And if we give a lot of ganciclovir, definitely we are heading for poor graft function. So I think CMV is a big issue. Hopefully with letermovir, we will be seeing less of it. What we have come to understand is in a PTCY or TCR alpha beta, GVHD is not a big problem. So when the child has a lot of loose stools, when the child has a skin rash, think very carefully before we jump in and add high dose steroids, because we are going to pay a price the next week because viruses will go out of control.
So this adeno and the CMV which you are battling, EBV. Now, adeno, you have, what is a trigger for? I mean, you are looking at all of this on a weekly basis, twice weekly,
On
or
a
once
weekly.
you do.
So all haplos have a weekly PCR for CMV, adeno, EBV.
And what is your response to adeno? What level do you start cidofovir?
Anyone who's above 500, we start. And the first
Adeno.
step is to cut back on the immunosuppression and then add the cidofovir, or do
So
both
alpha
in parallel.
beta. So in alpha beta, are you giving any immunosuppression at all?
So before we weren't giving, and then we found a lot of autoimmunity later towards 9 months, and especially so now we've added the rituximab. We're not seeing autoimmune hemolytic anemia until day 100. We are giving them some suboptimal cyclosporin. So we're
means
not
less than
aiming
one,
for,
less than 200,
yeah, so
less than
some less
150.
than 100. Yeah.
Wow. And in terms of the first part, when you are doing the harvest and putting it in terms of, I mean, and subsequently you are having this poor graph function. So apart from romiplastim, is there any other cocktail which you have to push this, because you are looking at 7 lakhs
I didn't get
versus
the question. Yeah. I didn't get
in
the
terms of
question, Joseph. I'm
poor
not
graph
able to hear.
function, poor graph function, apart from romiplastim or anything else you add on to push up the graph function?
So we found that when we used tacrolimus, I think it takes out a big chunk of the Tregs also. So when we see poor graft function, so we cut back on the calcineurin inhibitors and switch them over to a combination of low dose MMF and steroids. With that, the immune reconstitution seems to be better. And add romiplastin early. Don't wait for the platelets to drop low. When they're coming below 100,000 itself, add romiplastin early. We generally tend to avoid L-trombopac because it has a lot of drug interactions and
Liver issues.
hepatotoxicity. Yeah.
What's your usual antifungal prophylaxis during this period?
All of them are on voriconazole unless they can't tolerate it. Now, the new experience we've had is when we give letermovir to children, they are extremely sensitive to tacrolimus. So the levels are sky high. 0.25 once a day, we're having tacrolimus levels of 25. Voriconazole levels are high. So TDM monitoring for these two drugs has to be more aggressive because toxicity is higher when we combine it with letermovir. You want
So
to say
worry, of
something,
course.
Vidya?
Yeah, with
Mm.
GVHT, we have moved to posaconazole. When they have GVHT, otherwise standard has been voriconazole for most of these.
Any other questions in the chat box? Everybody is spellbound.
Ah.
No, it is good, fantastic. The nuances of fine tuning is something which we need to learn. So when you say TAC levels to be maintained, at what level are you targeting?
We do tacrolimus, we aim for 5 to 15 in the malignancies and 5 to 10 in immune deficiency, trough levels.
Benign,
But we
benign.
hardly use in immune deficiency, they are usually on low dose cyclosporin, especially if we are doing TCR alpha beta. Only if they get PTCY, they have tacrolimus.
So this concoction for poor graph function, saying that TAC, remove TAC and add MMF and steroid, it is, it's a very useful tip which you have given. And is that something which Biju follows or anybody else follows?
Towards day 100, actually, lot of them for PTCY, they come off immunosuppression, no? Because the whole thing with PTCY is you withdraw immunosuppression early. In the malignant cohort, it works well. But in the benign, non-malignant cohort, if you do that, they get immune cytopenias. So that's why we've added this and continued the combination till about 15 months. And then we've avoided immune cytopenias and poor graft function.
If a blip of EBV comes in between post transplant, how do you respond to that usually?
So cut back on the immunosuppression and recheck. And if it's increasing or if they have fever or they're symptomatic, we respond to EBV very promptly only if we're doing Recallo for Hodgkin's. All others we observe. And for Hodgkin's, give rituximab early.
Okay. Good, fantastic. Thank you for engaging with us in your sharing some of your secret tips in the recipe of transplant. Over to Biju for your comments, Biju.
Well, I think we've had a fantastic discussion and yes, a lot of learning that has been done. So should thank Revati and the entire team for discussing this case. I'm sure all the participants who were there, we've got close to 80, 85 people who have joined in. I'm sure they would have benefited from this. And I'll hand it over back to Diksha.
Thank you so much, sir. So, as we draw the curtains on the 11th episode of Blood the Life Savior, we extend our sincere gratitude to all those who have contributed in making this academic initiative a continuous success. On behalf of Intas Pharmaceuticals, I, Diksha Gehlot, take this opportunity to thank our distinguished faculty from Apollo Hospital, Chennai. Dr. Vijay Sri Muthukumar, Dr. R. Tulsi Raman, and Dr. Vidya Krishna for their valuable insights and participation that added depth to today's session. A special mention and heartfelt thanks to Dr. Revati Raj for her thoughtful summary and concluding reflections that beautifully encapsulated the key takeaways of this episode. Our deepest appreciation goes to our course directors, Dr. Biju George and Dr. M. Joseph John, for their consistent guidance, mentorship, and vision in shaping Blood the Life Savior into a collaborative academic platform. And finally, to our viewers, thank you for your constant support, enthusiasm, and engagement. With episode 11, we stand on the threshold of a significant milestone. The next episode will mark 1 year of this remarkable journey of education and collaboration. Over the past months, this series has connected clinicians, inspired young hematologists, and created a platform where learning truly saves life. We look forward to seeing you in the 12th and anniversary episode of Blood the Life Savior. Until then, stay curious, stay inspired, and continue saving life. Thank you and good evening. Thank you, sir.
Okay, bye everyone.
Bye.
Bye, sir. Thank you.
Bye, sir. Thank you.